All right, well, welcome everybody. My name is Aviva Ariel Donges, and I am one of the health psychology interns at Jesse Brown VA. And I'm also the student chair of the Society for Health Psychology's Student Advisory Council. And I'm very happy to be presenting our second speaker today. I just want to remind you all who are here in person that next week there's no live presentation. It's just going to be live streamed from my office in Jesse Brown. But for those of you who are tuning in, everything will stay the same. So on behalf of Dr. Jason Washburn here at Northwestern Feinberg School of Medicine and Dr. Sarah Catanese at the Jesse Brown VA, we want to welcome you to the Health Psychology Seminar Series for 2018. So the seminars each week will be Wednesday at 3:30 p.m. Central Time through November 14th. And for those of you streaming online, thank you so much for joining us. If you don't mind, just type into the chat box where you're calling in from so we can get a sense of how far and wide this seminar series is being disseminated. And if you don't mind making sure that your video and microphone are muted, but you're welcome to type in questions into the chat box, and at the end of Dr. Thilges' presentation, we'll check in and she'll be able to answer anything. So I'm honored to introduce Dr. Thilges, who's an assistant professor at Loyola University and in the Department of Psychiatry and Behavioral Neurosciences section of Psychosocial Oncology. Dr. Thilges completed her bachelor's degree at the University of Iowa and her PhD from Illinois Institute of Technology here in Chicago. She completed her internship at the University of Wisconsin Hospital and her fellowship at Loyola University Medical Center. Dr. Thilges is an expert in psycho-oncology. Her clinical work and research focus on stressors and resiliency factors during cancer, as well as family and couple dynamics and role shifts in patient-caregiver relationships. So please join me in welcoming Dr. Sarah Thilges. All right, let me get you set up here real quick.
All right. Thank you. It's always awkward hearing someone talk about you, but it's a good reminder of everything I've done. And a good reminder you guys will all get to this point someday soon, I promise. So I'm going to talk a little bit about working in psycho-oncology today. Obviously, it's a huge topic and hard to talk about in just an hour, but and I tend to ramble, but we'll see how we do. Sorry, we're not. Okay, so I know this is kind of a busy slide, but I like it because it shows all the different ways that psychology can be involved in a patient's oncology experience. So we tend to think about psychology being involved, maybe people think of at the time of a new diagnosis or possibly a change in prognosis, end of life, and certainly that's a big part of when we are involved, especially in the inpatient health setting, but there's many, many other ways in which psychology is involved, not the least of which is research throughout this entire process, but even thinking about the pre-diagnostic phase. So now with the availability of different genetic testing and knowledge that we have about the hereditary link of cancers, there's a lot of difficult questions sometimes people have to answer about whether to be tested for different possible genetic links to cancer, and then the implications of if they do find that genetic feature, what they need to do about it. So for example, most commonly people know about the BRCA gene, and women sometimes elect for an elective mastectomy, hysterectomy, if they know that they're a carrier of the BRCA gene. That decision obviously comes with a lot of psychological distress, especially if the patient is younger, prior to childbearing age, or has not had children yet. So that can be a place psychology is involved. Obviously, at the time of diagnosis is usually an acute stressor for people when they're coming to terms with what that means for their life. Throughout the treatment process, sometimes treatment can be very, very arduous, very, very long. Even in the remission, recurrence, and survivorship phase, I think that when we see people who are in those stages, those people seem the most surprised that they need to see us. And I hear even sometimes people expressing a lot of guilt that I should be glad I'm alive. Why am I so depressed? Or why do I cry all the time when I beat this? And so, when we see people in that context, it's really a lot of validating. A lot of times, if we think about kind of the hierarchy of needs, when you're not sure if you're going to survive, your focus is on what you need to do to survive, not necessarily on the emotional or psychological process of what you're going through. So it's not until sometimes the calm after the storm of survivorship or remission that people are really flooded with all the emotions they had to put to the wayside. So that tends to be a really common place we see people. And also too, an area people may think more of is end of life palliative care options when people are electing for hospice care, and the anticipatory grief patients do as they face their foreshortened life, and then working with families, caregivers of that patient on the grieving that they do, anticipating that loss. So how do we assess depression in patients with cancer? I think we know how important depression is in many health outcomes, and cancer is especially one of those. Both the direct ways in which depression can impact cancer care. So, they may be less likely to adhere to medication regimens, engaging in proactive healthy behaviors if you're depressed, maybe more likely to miss appointments, whether they're treatment appointments or appointments with their physician. There's all kinds of research. Hopefully you guys can all understand clearly the point where can lead to prolonged admissions, decreased functioning and status, and just in general linked to decreased survival time and increased mortality. Again, I think those direct and indirect links that we know of between depression and health. One of the challenges we have in assessing depression is the difficulty in measuring it. So if you guys think about a lot of the standardized assessments, the PHQ, they put a lot of weight on somatic symptoms. So in a medically healthy person, issues with sleep, issues with weight loss, issues with energy could pretty clearly be indicative of depression. For someone who's going through cancer treatment, all of those symptoms are side effects of cancer, of treatment. So, I have patients that you score that would fall under the severely depressed, but in an interview with them, they're not depressed. But just that measure, you could mark just the somatic symptoms for every day and show up in, the severely depressed range. So I think one of the struggles, both when we look at research in depression and cancer, is that the ways we have to measure that can sometimes not necessarily overinflate, but just misrepresent what the true experience of depression and cancer is. So ways around this are to do different classification systems, using a structured diagnostic interviews, and obviously our own skills as clinicians and doing clinical interviews is probably the best way. The Endicott substitution criteria looks at ways to substitute some somatic symptoms for other symptoms that necessarily wouldn't be found because of a cancer treatment or diagnosis. So looking at, change in weight or appetite, substituting for that a depressed appearance. And this is where it falls a little bit more on clinical intuition, but most of us by now, if you've sat in a room with a patient who's depressed, sometimes you just feel that depression, or you look at a patient, maybe kind of avoidant eye contact, shoulders are down, their face is flat, and we would characterize that as a depressed affect. And that we wouldn't necessarily think of as being caused by cancer treatment. It would more likely be representing a true depression. Risk factors for depression and cancer, a lot of these are going to be the same for risk factors in any other depression: past history of depression, family history, recent bereavement, substance abuse. Demoralization is I think something that at least it's a word I'm putting in my clinical notes more and more often because I think it's a good descriptor of patients who, maybe it sort of subsumes hopelessness or helplessness, but just not feeling optimistic about whether they're going to have a successful response to treatment or just their future or just their well-being in general. So patients who just seem beat up by life, by what they've experienced. Some different social factors when it comes to cancer. Age, we know that younger age at the time of diagnosis is a risk factor for cancer. And again, we can think of sort of expectations people have when you're 25. You don't expect to be facing a potentially life-ending diagnosis. The impact that has on relationships, on life goals, kind of where you are in your life versus patients who are 84 maybe have some expectation that it's likely they'll be at medical appointments, that they'll have some kind of physical functioning difficulties. Gender, we know that women may be more likely to experience depression, but we also know one of the confounding factors, women may be more likely to endorse depression. So whether it's true that they actually experience more depression or that we just better measure it or assess for it in women, and also possibly caregivers as well. Female caregivers tend to report more depression. And some of the caregiver studies you look at when men and women are caregivers, women tend to take on more responsibilities in addition to their caregiving role, whereas men tend to focus exclusively on one role, either the caregiving role or maintaining occupation, possibly to help with finances, insurance, whereas the women caregivers tend to be caregivers working, possibly also taking care of children, other parents in the household, so might have more stressors at the time. Some of the cancer-related risk factors during different phases of the treatment, patients can be at greater risk for depression. So usually when you look at, for individual patients, their experience with depression over time, we know that it's highest during treatment and then declines subsequently, which is what we would hope for all patients, that obviously when you're going through the most kind of acute stressor, that your distress is the highest, but as you hopefully slowly return to some normal roles and some normalcy of routines, that we see those mood symptoms start to improve. We know advanced disease at the time of diagnosis can lead to greater risk of developing depression. And again, it could be because treatment for advanced disease sometimes can be more physically taxing, more arduous. Also, patients are possibly confronting a poorer prognosis. Type of cancer can make a big difference, and I think probably likely this might be due to the effects of where the cancer location is on patients' quality of life. So there's some cancers that the disease, the treatment may not drastically decrease quality of life, and there's others where that may happen greatly. So if we think of GI cancers, patients may have different ostomies, they may have feeding tubes, have pretty significant pain and just changes to day-to-day functioning. And also neurological disorders that may be associated with cancer. So whether that's a brain tumor or metastatic disease to the brain or secondary conditions, sometimes people develop related to chemotherapy may also increase depression. Also probably likely to the impact on quality of life. Some of the issues related to treatment that can cause depression, uncontrolled pain, just like in any other condition. Pain is a very common and prevalent issue in cancer, and a lot of the opioids now that are part of the opioid epidemic were actually developed for cancer-related pain. Different physiological conditions, so some metabolic abnormalities, so sometimes different cancers, depending on the location, different treatments can impact, can make patients hypoglycemic, anemic, all these different things that can lead to fatigue, some of the depressed affect that we see. Steroids, some different cancer treatments involve incredibly high dose steroids. People can become very irritable, very anxious, develop panic attacks, depressed mood. I will not pretend I'm an expertise on cytokines. So if anybody has questions on cytokines afterwards, you probably know more about this than I do. I just know as much as what I've included on this slide, that a lot of the different issues associated with cytokine releases, which can come with cancer, especially depending on where it's located, if it's impacting the glandular, the hormonal system. And there's a lot of people who do research looking at just the cytokine properties and how they affect depression, and even looking at how antidepressants may have an anti-cytokine action, and that's how they're working on the depression. Cancer and suicide. This is I think a difficult area, especially for students who are maybe first starting to work in oncology, on assessing suicide, because it's pretty common, when we're assessing suicide, we ask about thoughts of death, thoughts of being better off dead, and I would be surprised if a patient with a cancer diagnosis hasn't had a moment where they've thought that. And so I think there is a lot of passive suicidal ideation that happens, especially when patients are really struggling with quality of life, or when they are facing a really poor prognosis. And along with that, so not just limited quantity, but poor quality of life. That being said, we never want to fall into a trap where we think, of course you feel that way, or of course you have that thoughts, you have this really terrible disease. And it's just as important to monitor and intervene on, because we also know that if we can address suicidal thoughts, patients' moods can recover. And so with whatever quantity they do have left, they can find more quality within that time, and also more ability to cope with it than they thought possible at that time. So we know rates of suicide, both ideation and attempts, can be greater than in the general population. Depending on cancer type, their current pain, the setting, rates can vary. We also know too that delirium may be an undiagnosed component of a lot of suicidal ideation. So hypoactive delirium can look a lot like depression, especially on the inpatient setting. We frequently get consults for patients that fall under the category of failure to thrive, who are sort of withdrawn from providers, withdrawn from care, not engaging in activity, and it looks very much like depression, but it's only with the amazing work of health psychologists that we're able to better decipher what might be more of a hypoactive delirium. So we certainly want to ensure that anybody who has any kind of suicidal ideation, that we're doing some kind of cognitive screen that might help tease apart these issues. Psychotropics used in cancer, sometimes it can be just what you would use in any normal population, but obviously chemotherapy, different treatments can create some challenges in using medications. We also know that psychotropics have multiple uses. So again, for a lot of our students who are first coming into oncology, they seem shocked that every single patient must have anxiety because they take lorazepam. Well, in the cancer world, lorazepam are the Tic Tacs. They treat nausea, they do obviously treat anxiety, helps with sleep, but very often nearly every patient will be prescribed lorazepam for nausea. Also, a lot of antipsychotics can be used in delirium, but also used in nausea that doesn't respond to typical anti-nausea medications. So again, other times, students will get worried and think, my patient didn't acknowledge any psychosis, but, they're on an antipsychotic. And so, that's where talking to the medical team or, further digging into the chart can let you know maybe what the indication is. And neuropathy or, nerve damage is a common issue patients have because of chemotherapies usually. And some tricyclic antidepressants can actually help with that neuropathy pain. So again, just a few examples of some of the dual uses. Another, what can be a really great medication in the population is mirtazapine or Remeron, and that can treat sort of the triad of issues patients have. It can help stimulate appetite, it has some antidepressant properties, and it can help with sleep. So again, with cancer, those three tend to be a common problem, and so that can be really helpful. Also, psychostimulants can be used, so modafinil, medications like that. I've seen those used in settings where patients have had really prolonged hospitalizations and are struggling with kind of initiative to start participating in physical therapy, start eating. It's almost like they're in slow motion, and they just, for lack of, despite, psychotherapy support, family support, they just physically cannot move forward. And stimulants can be really helpful, it seems, in helping them get over that initial hurdle and starting to engage in care. Also, too, palliative care may use stimulants to help people with a little bit of energy with, whatever limited time they have remaining. Sexual dysfunction. This is another huge issue in the cancer population. Prevalence rates, I have in there the range of 25 to 100%. And my guess is it's probably a lot more likely 100%. But when we're asking about it, it's going to be 1%. But that 1% is a tip of the iceberg. And again, this is an assessment method issue. If you think about just going to, let's say, a outpatient oncology clinic and you're going to go person to person and ask about sexual dysfunction, we know very few people are going to acknowledge it. So I think that's why studying this is so difficult. We know that there's multiple factors that can correlate to what causes sexual dysfunction in the cancer population and associated with increased anxiety, depression, marital or partnership conflict. When we're looking at sexual dysfunction in women, we look at some of the cancers, breast cancer, gynecological cancers. We look at those because they tend to be the most studied. They're kind of an easy population to capture. And also, too, because of the impact those treatments have on women's hormonal, physiological responses, their perceptions of their gendered selves. Mastectomies is a very visible reminder of what, experience you've gone through. Also, to a lot of the medications for the gynae and the breast cancer population, the treatments will put women into early menopause. So women in their late 20s will go into menopause and have all the hormonal implications of that. And also, too, the loss of childbearing potential, too, which can affect their sense of themselves as kind of a sexual entity. When we look at sexual dysfunction in men, we tend to look at prostate cancer. Again, it's an easy population to capture, and also because of the impact on hormone deprivation, some of the different surgical interventions patients have. When we're trying to assess this, I think the biggest thing for us as health psychologists is break the don't ask, don't tell culture. It can be difficult to loop into your assessment, but if it just becomes one of the routine questions that you ask, we ask a lot of invasive questions, and hopefully we know kind of how to ask them and how to qualify them. And the more normalized we make that question, the more normalized patients' responses back to us are. Same thing with physicians. If physicians made it part of the routine questions that they ask, pain, sleep, nausea, appetite, sexual dysfunction, it becomes that normal for patients to respond to as well. We know that when patients are uncomfortable talking about it with each other, they're also going to be unlikely to talk about it with their provider. I think in my personal experience, I think it's honestly 50-50 of patients and partners who bring it to the attention, whether it's of me or of their provider. So maybe too, when we have the opportunity to talk to partners, we might want to include them as well. I think there's a lot of complexity to this issue. One of the biggest issues when I'm working with a dyad is it seems if the partner has been a primary caregiver for the patient, it can be a challenge because you think about all the different role shifts that's involved. cancer's messy. And, when a partner has become a caregiver, they've potentially been bathing their partner, they've been changing diapers, they've been dealing with vomit, all the messy details of day-to-day life. And to then sort of resume a sexual relationship can be very challenging for the partner. But then I've heard from partners that they have a lot of guilt about this, acknowledging that they just don't see their partner, quote unquote, in that way anymore. And they can feel really guilty about this. And then patience, we can think about all the self-esteem issues that are associated with changes in appearance, not to mention just the low sexual desire that can come from some of the different hormonal and some of the different medications that people are on. The Plicit model is kind of a model of how we address sexual dysfunction. So P for permission, encouraging the patient to discuss, validating, maybe even giving a little spiel about how high we know the prevalence rates are, providing some limited education. That may be a handout. The American Cancer Society on their website has an amazing manual for both men and women. Each is like 50 pages long, and it goes through all the physiological, physical, psychological components of sexual dysfunction. So they're great manuals to have on hand, and you may take out a little piece that's directly, related to your patient and their partner. But that's great information. If you kind of get the sense they're uncomfortable talking about it there, send them home with something that they can read, that they can share with their partner. Offering specific suggestions, so like sensate focused therapy, which you can find if you Google it, you can find just a little like one-page descriptor on what it is, but essentially it helps a partnership rebuild intimacy without focusing on sexual function. So one of the rules of it is that kind of sexual intimacy is taken off the table with focus on just rebuilding intimacy in general. And so that can be an easy intervention, even if you don't consider this like an area of your expertise that you can suggest. And then if you get the sense patients need more intensive treatment, you could refer them to providers who specialize in sexual dysfunction. Interventions, important also too, if a patient does bring this up as a concern, to always refer them for a medical exam. You can imagine if somebody's got, like for a male patient with a prostate cancer and is having erectile dysfunction issues, if you're addressing this from maybe an anxiety component, they're doing all this work, they're continuing to have issues, it could be resolved with a medication. And not saying the self-esteem issue isn't also important to address simultaneously, but it's important that they're getting all the resources that they can. And CBT, so sort of identifying some of the schemas patients have developed about themselves or about their partner that may be relevant. These are some slides I got from a really great conference I went to 2 years ago on cancer survivorship at Fred Hutchinson. And I think it just gives us another way to look at cancer care. We look at the direct cost of it. By 2020, this was from someone who works for the American Cancer Society, that they estimate cancer care will cost nearly $160 billion in several ways, both in medical costs associated with survivorship. So we know survivors tend to have more comorbid health issues, and also lost productivity and people who may not be ever able to return to their jobs. So patients who do maybe very physical jobs won't be able to return to those jobs, or patients who do very kind of higher level cognitively demanding jobs may struggle returning to those jobs as well. Good news is we're getting better at curing cancer, and there's more cancer survivors, which is wonderful news. But it also means now we need to shift some of our focus too on treating these cancer survivors and not just celebrating that they are survivors. Because when you look at survivorship, patients are still reporting a lot of issues. So compared to the general population, reporting more psychological distress, more difficulty just performing activities of daily living, more functional limitations, and more work impairments. So the cancer may be gone, but the effect of the cancer isn't gone. The cost on the patients, unfortunately, cancer care is expensive. Survivors are more likely to file bankruptcy, and then patients who have filed bankruptcy are more likely to have earlier cause mortality. You think about that, they may lose health insurance, may not be able to afford some of the healthy foods, things like that needed to care for themselves. There's been a push recently to be more upfront with patients about their cancer care. So I know at another institution, they were actually providing patients with their estimated cost of all of their treatment at the time of diagnosis. And you can think about the intention is just so that people are aware, but unintentionally what happens is people then make judgments about what their life is worth. And I've heard from numerous patients, I'm 74, this treatment may only prolong my life by 5 years, but I will leave my spouse or my children with nothing. Is this treatment worth it? I'm seeing a woman right now with recurring cancer that she was recommended to have radiation after her initial diagnosis. She wasn't able to afford it, didn't do the radiation. Now the cancer has returned, and a lot more prognosis is pretty poor right now because of how much it's spread. And they can't directly say it wouldn't have come back if she had the radiation, but it would be a lot less likely. And those kinds of things I think are just, it's hard for us to see and to know that people are making judgment calls based on the cost of their treatment, but these are very real things that patients are experiencing. Patients are sharing medications, they're cutting medications in half, they're not picking up medications because they can't afford it. There's all kinds of issues with insurance. Insurance will decide some treatments are novel or they're very well established to be a curative treatment, and so physicians have to fight to get approval for insurance. But before we get into a political talk, we'll go into mindfulness. Mindfulness, I think, is such a great and wonderful intervention for this population. Sometimes I struggle with some of the CBT tenets. If we think about CBT, it talks about maladaptive thoughts, and we talk about dysfunctional thoughts. Well, for a lot of patients, a lot of their worries, their fears, the sources of their distress are very real. For patients who are in remission, fears of recurrence, it's really hard to sort of invalidate that that's a concern. When they feel this lump or this bump might be cancer, in a normal population, we sort of say, well, what is the likelihood? Let's look at the ratio. Let's test the reality of that. Well, for someone who the last time their lump or bump was cancer, that's not going to work for them. Also, too, when you work in this field, every lump and bump you think is cancer. So you can practice these techniques on yourself as well. So I really like mindfulness techniques for just accepting that, yeah, this is a really hard thing you're going to have to live with, possibly for the rest of your life. Every lump and bump to you, to your loved ones, to your provider is going to be worked up for cancer. And how do you live with that anxiety of not knowing? I think looking also to couples-based interventions, I really am passionate about couples work within this field for so many different reasons. We expect a lot of caregivers, and I think now we're starting to attend a little bit to caregiver burnout, but all we really do is encourage caregivers not to get burnt out. We don't really make a way for them to not be burnt out. So again, related to that earlier slide about finances, I mean, you can imagine very few families, they're dependent on two incomes. If you all of a sudden go down to one income, that's very challenging, let alone if we expect a caregiver to also be available 24/7 for a patient's needs. They may not have an opportunity to not work. They may carry the insurance. Bills still need to get paid. Depending on the age of the patient, there's potentially young children at home, so they're caring for young children. They may be caring for an aging parent. They're caring for the patient. And, we still encourage them to practice their self-care and take time away, and sometimes that's just not possible. So I think doing a couples-based intervention is really important. I think it's important also that patients, when I'm working with couples, I work on ways the patient can support their partner. So often when they become a patient, it's like all their capabilities get taken away from them, and they still have ways that they can be a spouse, they can be a partner. And I think it allows them to feel like they're caring for somebody rather than only being capable of being cared for. And so I'll talk to patients about asking your partner when they get back from work, how was your day? And it's ways not just to support the caregiver, but also to help the patient remain relevant within their partnership. Because we know that unfortunately this stress, especially when it's untreated, can build and build and build. And the caregiver can potentially start to feel resentful. And I hear, when patients or caregivers say this, they acknowledge the guilt they feel associated with that they know their partner is physically suffering, is going through something difficult, but they feel resentful that no one ever attends to their needs as well. And when we don't acknowledge that distress, we know that patients and their partners are at greater risk of divorce or separation down the road. Another way we can intervene in this population is something as easy as psychoeducation. So especially when you're working on the inpatient side, there's so many people that I know would never call me up, schedule an outpatient visit, come to a mental health clinic, sit and fill out forms. They would never cross that threshold, even if the need was there. But when we get an inpatient consult, we're essentially walking into their home and we're providing this mental health care. So we have to overcome a lot. We have to overcome some of the stigmas associated with that may be cultural, personal, whatever it may be. So a big role that we can do is just psychoeducation. It's amazing the relief patients can feel when you just tell them, give them a name for something that they're feeling, or validate that that's a common concern, and they feel not crazy. They feel not alone with how they're feeling. So really something seemingly so simple to us that we just feel like we know, so many people don't know, and being able to discuss that with them can be really helpful. So things like sleep hygiene, different techniques for managing pain, like we talked about, some of the normalization of sexual dysfunction, talking about some of the side effects. Again, I know we're not physicians, but you may just through your time working in this area or working in psychology know a little bit, like super whopping high doses of steroids can make you feel anxious and irritable. It's amazing how many patients don't get told that, and so then they wonder why all of a sudden they're just feeling overwhelmingly panicked, or their partner is saying they are terrible, they're being a jerk, I don't know why they're treating me this way. And identifying this as a side effect just is such a relief for everybody. And providing things like social support, whether it's groups or any kind of, the different cancer wellness centers that are when we're looking at end-of-life care, we don't often think about sort of the phases of that. But when we look at illness specifically, so you have your pre-diagnostic phase, that's where patients have some kind of symptoms. They may know something's wrong. They may be going to different providers who can't find them an answer. They may be ignoring the symptoms. But whatever happens leads to a diagnosis. Then you have your acute phase where you're sort of focused on, okay, I've got an answer for this. I'm starting my treatment. Your chronic phase where you may have finished treatment and now you're in the limbo. Did the treatment work? Did it not? Am I in remission? Am I cured? And then you have where the path can deviate, either the path of recovery, of survivalship, or the path of terminal illness where the disease is no longer considered curative. Similarly, there can also be a different trajectories for dying. So a gradual slant would be a long, slow decline that can sometimes last years. The challenges associated with this: long-term suffering for both the patients and their family members. It can drain the resources, both financial and emotional. You imagine the just emotionally taxing nature of potentially watching somebody over years just decline, knowing that death is likely, but that it's going to be a very, very slow process. There can also be a downward slant where there's a really rapid decline, and this can be shocking for patients. They may get a diagnosis, the disease could be very advanced by the time they find out about it and be told, you have weeks to months to live, and that may end up being what happens. And you can imagine the shock associated with that, both for patients, for families, limited time that you feel you have to prepare. And then other two trajectories can look a little different. So peaks and valleys. These may be patients who are on their third or fourth recurrence of their cancer, or patients, some of the treatments that we do can cause cancer. So especially you'll see patients maybe who had leukemias or lymphomas in their 20s. The treatment was super high dose radiation to, the torso, to the chest wall. For women, they're at increased risk for breast cancer. Men can be at increased risk for lung cancer, 20, 30 years later. And you can think about that sort of the demoralization we talked about. You get your hopes up, you're in remission, just to have a recurrence. You get your hopes up, and you can imagine that over time, you start to not get your hopes up anymore. And then descending plateaus can look where patients will have some improvement in symptoms, decline a little bit, improve, but each time they improve, it's not quite as much as before. And so you can, again, kind of see this gradual decline. Death is bad and death is hard, but there's certain factors that can make people have more distress during that process. We know when symptoms aren't adequately controlled, specifically pain, when patients have altered mental status, and this is why palliative care is such an amazing field, because they can do so much to help with the symptom control. Also younger age, again, we think about the expectations. You're not expecting to face your death at 25. I put in there avoidant coping sometimes because we tend to think about denial being bad, but I've also seen really beautiful acknowledgments of denial where patients, their actions are saying they know they're dying, they have their will in place, they've identified their power of attorney, they've had these really meaningful, wonderful conversations with their families, with their loved ones. And then they say, we're done talking about death. And they plan a trip to Disney. And, they may not buy themselves a ticket, but they work on planning it for their family. And they decide that they're going to talk about going to the Super Bowl in 10 years. And, they do all these things. And to me, when their actions are saying they understand, but they choose to not confront it every day, I think that's a way denial can actually be a healthy response, and sometimes the only response in these really difficult moments. And then we know social support can be a major factor. So if you're working with a patient that has either limited or complicated social support, there's sometimes really amazing programs that are there that can help patients. So whether it's some spiritual supports, I know at Rush they had piloted a program where med students would sit with patients who are dying that didn't have limited support. And it was an opportunity for medical students to become comfortable with what might become a part of their practice, and also for patients to have someone with them. And I think that is such an amazing program. I would love to see everywhere. So take that to your institutions and develop that, please. I also think too, we can try to separate out grief from depression. They can sort of look like each other, but we would treat them very differently. Maybe one of the biggest ways to differentiate is that we think of depression can be a transient mood state, decreased interest, decreased pleasure, but grief is more possibly a reaction to a loss. And there's ways to help patients work through both of those ways, but it might be helpful for us to know exactly what's happening. I don't know that they're mutually exclusive. I think you could be depressed and grieving and vice versa. But I think important for us to sit down with patients and their families to better identify what's happening, because you'll see a lot of medical providers say this patient's depressed when what they really may be doing is a healthy, normal grieving, anticipating what is going to happen. Anticipatory grief, thank you. So Like I've mentioned a lot, I kind of gone over a lot of these points, can occur in patients or caregivers. We look at Elizabeth Kubler-Ross, the denial, anger, bargaining, depression, acceptance. It's amazing to me how often patients really truly do go through those different experiences, as we know, not necessarily in that order. And they may linger in one phase versus another. But if you've worked with patients at end of life, it's pretty common to look back at points that you could kind of identify each of these domains as having occurred for them. And we know some of the ways. I like this model for looking at grief. Crisis is sort of, when you first learn the news, patients or families, they may come together, the upheaval to your life of what happens, the resolution of past issues. There's really amazing experiences that can happen for patients at the end of life with prior family members. Also, too, if you know of complicated family dynamics, I think it's really important to try to intervene. Right now, we have a patient in his early 50s who's in hospice and has probably hours, maybe days, and has a teenage daughter that had a lot of difficulty with his illness and the way it impacted their lives. And he told me as of a couple months ago would say things like, "I wish you were dead." And his health declined pretty quickly. At that time, his death wasn't imminent, but I haven't had, and she's been pretty guarded in talking recently, but I can only imagine the complexities of her grief right now as she's sitting at her dying father's bedside, probably reflecting on times she had said, "I wish you were dead." So when you know those dynamics exist, I think it's really important to try to intervene when you can, and potentially allow for some communication that will allow the family member to have peace later on. So then the final stage we would think of as renewal, that it's not always peaceful. There's sadness associated with that, but that both the patients and their loved ones can feel some sort of ability to look forward and to look beyond what's going to happen after the patient's died. Different ways of looking at grief, but if that. When we're communicating with patients and families, different things I think are important to look at are different domains. So how do they understand the illness? What does it mean to them? How have they coped with stressors in the past? What is their social support system like? What stressors are they dealing with concurrently in addition to their diagnosis? What other psychiatric vulnerabilities do they have? So history of anxiety, depression, substance abuse. We know that faith can be a really strong resource for a lot of people, especially when they feel a loss of control. So asking, does faith play a role in your coping? And this kind of highlights some of the, risk factors we talked about earlier for leading to depression, distress, and I think just gives us different ways of approaching patients other than saying, "How do you feel?" It gives us specific areas. So when we think about, what is a quote unquote good death, we want to optimize the patient's physical comfort. Again, so palliative care, palliative care, palliative care. Allow them to maintain some sense of self where things that were valuable and important to them can still be important. So if they're a parent and that role is very important to them, could they, I've had quite a few patients write letters to their children at different important events for them. Ways to enhance relationships, talking to that brother that you haven't spoken to in 30 years, making meaning out of their life, and having some semblance of control. Whether that's preparing a will. I had one patient who wrote down like the garage code for his wife and like just all these different day-to-day things that he had managed, and it was really helpful for him to do that. He felt like he was kind of leaving her with a manual, and that helped him feel a little bit more peaceful. So when you're working with patients at end of life, one of the biggest things I think to be aware of is our own experience in this, monitoring your own avoidance. So those times you think, you might peek into the room and it seems like the patient's sleeping, and so it's easy to just sort of leave and say, "Oh, I think they were sleeping." And it's okay. It's incredibly hard to work in this area. So just being honest with yourself, monitoring your own countertransference, that if it's a patient you've worked with for a long time, or it's a patient that for some reason their story resonates with you, they remind you of your mother, or they're your age, or they were born a week before you, or something like that. It's normal, and I'd worry more about you if you didn't feel sad. So making sure that you've got a good support system yourself, hopefully like a mentor or a supervisor who can help you navigate some of this. Knowing that the pace and intensity may be different. I know there are some manuals on, like Death with Dignity, and those can give you guides, but you're definitely not going to go page by page through some manualized treatment. And there may be times that you're in there and you're doing sort of the patient's doing a life review, and you may think, is this psychotherapy? I don't really know what this is. But I think of, if you're offering a supportive presence, then you're offering a psychological benefit. And so it may be just sort of sitting by the bedside. It may be listening to stories that they're telling you. And that's just as important as any quote unquote more, validated technique. Like I said, being aware of your own support needs and reaching out for that, knowing that no one is invincible, noticing your own grieving and guilt through this experience. I might mangle this quote, but there was a quote I saw in a New York Times article that I love that was, we can be strong enough to witness suffering, but human enough to not be impacted by it. And I think that's a good example of us at the end of the day. We're people working with other people who are dying, and that's really hard. And so practicing your own self-care, which I know you guys hear all the time, but I'll be another voice telling you to do that. So why would you work in this area? I didn't mean this to be a job talk to convert anybody over, but hopefully I have. So I think if for anybody who's worked in this area, like if you are passionate about health psychology, to me, cancer encompasses all aspects of health. There's prevention, there's coping with change in quality of life, there's treatment adherence, there's distress associated with sense of self, there's family dynamics, dynamics with medical providers, navigating the healthcare system. So from just a health psychology perspective, it touches on any area I think we'd want to intervene on. And there is something about this, not to sound cliche, but that's just so fulfilling, to know that potentially an intervention, a moment you've had with a patient, with a family, can be a lifeline for them on what could be the worst day of their life. And that's something we have to offer that really no other area could. And I think it's rare to be able to do this. And again, to bear witness to some of the suffering that people go through and are resilient through is powerful. So that's why I work. Hopefully you will too someday. So that's my presentation. Any questions or thoughts or anything? Yeah, type in.
One thing about therapy was that it's not always.
Yeah, I mean, cancer may be the reason they're dying, but I feel like for a lot of patients, they've kind of moved on beyond that. Like, it's like, okay, so that's the reason. Now I want to go back to who I am as a person. They've been poked and prodded and been through machines and been bald and had all these things happen. And now they just want to go back to who they are. Like, I find that in any sort of end of life work I've done, we don't usually talk about the cancer. Like, we talk about maybe, what they're going to miss and what they're going to regret and be sad they're not alive for, but it's not really about the cancer. So, which is always surprising. You think that would be the focus, but it's really. Go ahead.
Hi. I was wondering, I didn't hear, I wasn't exactly sure if you were doing research or not, but one thing I've heard from some people is like people lesser well-known cancers or just like even that are underrepresented in research. I felt like people don't care as much about them. They'll see like driven stuff, and it's like people care so much about breast cancer, but feeling like left out in their own diagnosis and their own experience. And given that like each treatment and each cancer can have so many different like consequences, and I was just wondering if that's something that you've ever come up with people.
Yeah, you are spot on. And I always hear pink ribbons as being like the identifying because which is wonderful. I mean, we have so much, and that's why breast cancer survivorship is so high. But I work a lot with head and neck cancer, and I hear a lot from that population. I think, it's not as, it's icky. It's a very graphic cancer. A lot of times it is correlated with smoking, with alcohol use. I think people feel a lot more stigmatized. And I do hear from, where's the head and neck cancer walk, or, these rare cancers, and they don't have their ribbons and they don't have their month and the buildings don't get lit up. So I think people can struggle because they can feel more isolated than they already do because of their cancer. The good news is there is a support group for anything. So it may be online, there may not be a chapter that meets locally, but there are always a support group. So maybe helping them find connections through there, or if they are kind of an empowered person, having them maybe start a group locally could be a way that they can build up some support. But I think, just validating it. Like they just want to hear your cancer matters just as much as breast cancer, even if we don't have it on yogurts, and so that can be really helpful for them to hear.
I was just going to ask more about. So it sounds like, is there like opportunities to survivorship?
Yeah, so I've always worked at like an academic medical center, and so my roles look pretty similar where I do outpatient psychotherapy with people, all spectrums of the cancer experience, see people inpatient, sometimes follow them as they're bouncing in and out. I've worked a lot in stem cell transplant, and that's why I really like that area because patients have to have a pre-transplant psychological evaluation. So, and sometimes too, I've even seen them when they've been originally diagnosed with the cancer. So I've known them since that point. I see them when they're preparing for their stem cell transplant, follow them inpatient through their